Welcome to the Fortrea podcast. I'm Friedrich Mittermayer, a Senior Medical Director for Endocrinology at Fortrea. And today we are diving into a critical and often overlooked challenge, the challenge in the race to cure type 1 diabetes, adult diagnosis. While the science behind disease-modifying treatments and cell and gene therapies is moving fast, too many patients are still being left behind. And why is that the case? Because they're diagnosed too late or misdiagnosed entirely. In fact, up to 44% of adults with type 1 diabetes are initially told they have type 2 diabetes. And that delay does not just affect care, it can mean missing the window for life-changing clinical trials. This is the first of two podcasts where we are joined by Breakthrough Type 1 Diabetes. And today I have the pleasure of talking with Dr. Esther Latres. She's Vice President of Research at Breakthrough Type 1 Diabetes. And together we'll explore how we can rethink trial design, patient identification, and access so that the right patients get the right therapies at the right time. Let's get started. Esther, Breakthrough Type 1 Diabetes vision is a world without type 1 diabetes in all stages and ages. Can you help us understand why it's important to emphasize that type 1 diabetes isn't just a pediatric disease?
Thank you, Frederick, for providing the opportunity to discuss such an important subject. It's true that we usually are focusing on pediatric and diagnosis and sometimes therapies, but this is, as you mentioned, the vision of Breakthrough T1D is a world without type 1, and that includes all stages of progression and also ages. So just to understanding disease progression requires distinguishing between the different stages. When we talk about stage 1 and stage 2, these are stages where the autoimmunity has started, but there's still no clinical manifestation. So this sometimes require, not sometimes, in most cases require some screening, whether it's a genetic screen or whether it's a detection of autoimmunities through autoantibodies. So these are preclinical diagnosis of type 1. And then we move into the stage 3, which is the new onset, and then later on to stage 4. So this is an area of very intense research that it started a long time ago. And we know that in pediatrics, the progression is pretty much very well studied. There's the presence of 2 or more autoantibodies definitely predict moving into later stages, and then followed by some dysglycemia that it's not being clinically manifested. But there is period of dysglycemia that correlates with the progressive loss of insulin-producing cells in the pancreas. And then by the time that an individual reaches a stage 3, which is the insulin dependence, that's when there's not enough beta cells to provide insulin independence. So the adult diagnosis and manifestation, clinical signs are heterogeneous and are more heterogeneous than in the pediatric. Sometimes there are cases of adult diagnosis that maybe the genetic component is not there, or maybe the autoantibodies, this multiple autoantibody diagnosis is not present. Sometimes it develops in adult with one antibody. So it's definitely more heterogeneous. So there are other components that maybe needs to be incorporated into the diagnosis, not only genetics or autoantibodies.
Mm-hmm. Thank you. So, as you just said, it's more maybe it's more difficult to diagnose the disease in adult patients, and so it can take a long time. It can take up to 2 years or longer until you actually diagnose the patient correctly. Can you walk us through what this diagnostic journey usually typically looks like until you find the diagnosis?
So I think you mentioned in the beginning that about 40% of adults are misdiagnosed with type 2. We've started investigating. We don't know a lot about the path and how to better diagnose, but we've done some studies in adults, and it takes some time. We did some retrospective studies, for example, and we took some cohorts that include individuals that they've been correctly diagnosed with type 1, We've taken another cohort with individuals that they've been correctly recognized with type 2. And then another cohort that was included, or it's included in the study, is individuals that were originally diagnosed with type 2, and then over the time, mostly 2 years or even longer, they were correctly diagnosed with a type 1. They received correct diagnosis. So in this cohort, depending on what you're looking at, so this population that gets first diagnosed as type 2 can go from 10 to 30%. Right. And the studies that we are doing are, again, retrospective studies, and they're using electronic medical records that can help identify, in that case, how these individuals were correctly diagnosed. So, for example, it includes age, it includes insulin therapy, it includes specialist interactions, HbA1c, hypertension, glucose levels, and with all these different measurements, we started building machine learning algorithms that can identify in this population, for example, what characteristics are more prominent in type 1 versus type 2. For example, younger individuals with a lower body weight. Maybe they have less encounters with hypertension diagnoses, or higher HbA1c, higher glucose, higher insulin refills, and also higher interactions with specialists like endocrinologists. These are measurements in the medical records that can indicate that maybe these individuals are more a type 1 versus type 2. So these are obviously early phases of these algorithms, but we started working on one database, and that needs to be proven and validated in multiple different other ones. Genetics also can be included. So it's a very exciting path to improve diagnosis in adults.
Yeah, that's very interesting, and I think this is something which is really missing to have something like an algorithm to find these patients. I mean, if you are a specialist, you are trained to that. You can find that out, but most patients are not diagnosed, I would say, by endocrinologists initially. So it would really be good to have this, and not only for the treatment of the patient is important, but as we discussed before, also for identification of these patients early, so that immediately once we have the diagnosis of diabetes, that we really know, is this type 1, type 2 diabetes patients, also so that we can get these patients into clinical trials that usually have this small recruitment window if these are disease modifying treatments.
Yeah, this is very important, and the correct diagnosis, right? But also, I think you mentioned that sometimes in adults they are seen by different healthcare practitioners. Maybe they can be diagnosed by different healthcare practitioners and care. So I think that having this algorithm, or at least some initial indication that an adult presenting with diabetes signs can be a type 1, can be followed. For example, can it be followed with a C-peptide test, or can it be followed with an autoantibody test? Or maybe we can look at genetics. But I think presenting with a follow-up after presenting with symptoms that are maybe in the borderline of a type 2, but maybe type 1, I think there are tests that could be followed regardless in what setting they get diagnosed. And I think you also touched very importantly on the timing, right? I think, again, it's a little different in the pediatric, where the decline of beta cells keeps declining after diagnosis quite fast in some individuals. In adults, the progression seems to be a little slower. Maybe that's why there's a window of 100 days, mostly in pediatric clinical trials, because we know that as the first 3 months, the higher the C-peptide levels, the higher chances one may have, or a therapy may have, to maintain these higher levels of C-peptide. But in adults, it's also important not to wait a year or 2 years to get the right diagnosis. So it is important to get a right diagnosis and getting it in a timely manner.
Absolutely. And you're mentioning a very important point here. It's this window, when we go back to clinical trials, this 100-day window. as you said, it's important in pediatric trials, but maybe there would be an opportunity to really increase this when you include adult or older patients into clinical trials, because as you said, that the beta cell decline, the decline of beta cell function is much slower in adult patients. So you also have a larger therapeutic window where you could actually intervene. And when you increase the window from diagnosis, you are able to include many more patients into clinical trials and also get this information. But
Yes, I agree.
yeah, yeah.
No, I mean, I just want to say that maintenance of C-peptide, some
Mm-hmm,
functional C-peptide that come from your beta cells, that come from the organ that is supposed to
mm-hmm,
secrete and sense glucose, even if the levels are low and they cannot support insulin independence, there's a lot of reports and a lot of data that even low levels of C-peptide, maintaining low levels of C-peptide can provide some benefits long term in
yeah.
terms of complications, benefits in HbA1c. So I think that regardless of an adult or a pediatric, whether you intervene early in pediatrics or late in adults, as long as there is some C-peptide that remains
Mm-hmm,
that's physiologic, right?
yeah.
We know that insulin is secreted in the pancreas, but mostly goes
Mm-hmm,
first into the liver. And the way that insulin therapy is administered through the skin, it's not a physiological
mm-hmm,
way. So maintaining some levels of C-peptide that are
mm-hmm.
significant to prevent complications and provide future clinical outcomes, I think it's
Yeah.
very important.
Absolutely, absolutely. Yeah, you're raising a very interesting point here. I mean, one could assume that actually you might not need a window. You could just include patients based upon the residual C-peptide that they have. So regardless if it's 100 days, 1 year, 2 year, there are adult patients with type 1 diabetes that had diabetes diagnosis 3, 4 years ago and still have significant C-peptide levels. So
Yep,
um,
absolutely. There's a lot of
yeah.
correlation on complications, for example, microvascular complications. There's a lot of population studies looking at individuals that maintain higher levels of C-peptide and that
Mhm.
correlating it to, better outcomes. So it's
Yeah,
absolutely an important point.
very important. And I think we don't see that yet in the clinical trial world. Usually in most trials, we have this window. So it might be a new approach that companies could try to follow to
Mhm.
actually use the residual C-peptide levels as inclusion criteria.
Yes.
Yeah, yeah.
And I think that some therapies, again, depending on safety,
Hmm.
depending on the risk benefit, maybe tested in adults first. Not that they have to,
Hmm.
any therapy, but
Hmm.
some of them, when we talk about maybe some of the more experimental therapies or immune therapies or immune cell therapies, I think there's an opportunity to test also some of these more new emerging therapies in adult population.
Hmm. That's a good point. Usually it is much more difficult to actually start in children with these treatments. And as we just discussed, as you said, there might be a better approach just to do these trials first in adult patients. And you could also think of increasing the age range, because what we usually see, especially in the disease modifying treatments, that the maximum age is set at 30 to 35 years of maximum. I have seen 40, 45 years in these trials, but this could be further increased to older age groups, especially since older patients might have even more benefits because they have more C-peptide. If you use disease modifying treatments. And I think when we spoke before, you mentioned a very interesting case of a patient. Yeah.
Yes, so I think for the adult diagnosis, it presents a challenge, and this is just anecdotal case, but I think I keep hearing sometimes. I go to a lot of research gathering
Hmm.
and stakeholders and events, and I get approached with cases and challenges that people living with type 1 face, especially in the new adult diagnosis, for example. And for this individual, it's been a type 1 for a long time. It's been living for a long time. And his mother took care of him when he was a child, obviously growing up with him having diabetes. And then at some point in her 70s, she started to develop symptoms of type 1. And it was really hard to get doctors sometimes, or to get into the emergency room to like convince, even running tests for type 1, right? It's like
Mm.
we don't see these
Yeah.
cases, but
Yeah.
they happen. They may be very rare, but being family member, we know that family members may have a higher
Mhm.
risk of developing type 1. So with all the justification for running some tests, uh, this individual, it was really hard to convince. And obviously they were in a way very familiar with the symptoms and very familiar on pushing and finally being diagnosed with type 1. So
Mm.
that's a case where it really reflects how the misconception that someone can develop type 1 at that age, but it happens.
Yeah, I think, yeah, that's a very nice example that illustrates what the clinical perception of in the healthcare community is about type 1 diabetes. I think it's mostly still considered a pediatric disease. You might have some younger adult patients that develop type 1 diabetes or latent autoimmune diabetes of the adult, but it can happen anytime during the life, actually. And I think education is very important to get this out to, I mean, specialists, they know that, but as you said, it might, for someone who is not a specialist, and even for specialists, sometimes
Yeah.
they would say, okay, 70 years, we don't need these tests. This is not type 1
Yes,
diabetes. Yeah, yeah,
absolutely.
yeah,
Absolutely.
yeah.
So we're definitely doing a lot of work on communication, education. Especially, it's important also for clinical trials. I just want to go back to something you mentioned before, because we're running some clinical trials, disease-modifying therapies in the new onset in adults. For example, we have this, and importantly, some of these therapies have been approved for other indications. So, for example, verapamil
Mhm,
is one of these drugs that are compounds, therapies that it's been approved for blood pressure medication, but it's been through some research and some initial clinical trials, it's been shown to have an effect on the distressing beta cells at the time of diagnosis, right?
mhm,
So this is a therapy that can be used in the new onset. It's being used in pediatrics, and also it's being tested now in pediatrics and adults. The safety seems to be a reason,
mhm,
we'll see the clinical trials, but it's pretty safety. It's available. It's a genetic drug. It's important that maybe adults get rightly diagnosed with type 1, that can get access to these therapies, that they can
mhm,
really make an impact on their maintenance of C-peptide. These drugs are already approved, that
mm,
the safety is known. So we're doing a big effort to making sure that adults in the new onset have access
mhm,
to these clinical trials and these therapies.
mhm. And that's it's really important. It's really great. And when you, as you said, when you have a drug like verapamil, I think when you see the trial results, when you see that helps, it's very easy for patients to actually get this once if they are diagnosed in time. So you could prescribe this immediately and help. I also like to go back to that. Previously, I think the thought was, okay, you need to get insulin independent, and insulin independency is the goal. But as you said, and this is also something we see definitely in clinical practice, when there is some C-peptide, you can support with insulin, but it's much easier than when there is no C-peptide left to control the blood glucose levels in this case.
Yeah. I mean, we're doing some studies now on continuous glucose monitoring and time in range. I think one of the challenges is the glycemic variability, the daily
Mhm,
changes, and keeping it time in range, and working on the benefits of maintaining maybe C-peptide, or when some of these drugs can be used to maybe decrease a little bit the, the variability, or work with continuous glucose monitoring in achieving improvements in time in range. So I think there's a lot of opportunities providing these disease modifying therapies from the beginning, from the diagnosis.
mhm. And maybe there's a question that comes to my mind here when we were speaking about disease modifying therapies, but when it comes to cell and gene therapies, for
Mhm.
example, would you see it in a similar way, or is this
Yeah.
something? Yeah.
Yes, as you know, the cell islet transplantation is
Mhm,
being therapy that's been available successfully for over 20 years. It is restricted to a population of severe hypoglycemia unawareness and repeated severe episodes of hypoglycemia. The restriction is obviously using donor islets, but the main one is immunosuppression. We know a lot about immunosuppression now after 20 years. We know what the side effects are. We know much more. So this is another area. I think the risk and benefits, they need to be measured, obviously by clinicians, by regulators, but also by people living with type 1. That maybe not in the pediatric setting, but I think in the adult setting, I think it's an area where the risk and benefit ratio needs to be expanded in populations. That's something that probably is going to happen gradually. Breakthrough T1D has a big portfolio on the next generation therapies that will remove broad systemic immunosuppression, maybe finding ways or localizing immunosuppression to the graft, to the transplant site, using engineering and using other technologies. There's now very exciting data coming from the clinics that cells can be manufactured and can be upscaled, and these cells can work. These are sources that can provide and extend access to islet transplantation. These manufactured cells have the ability that can be gene edited to remove some of the signals that are involved in attracting the immune system and causing rejection. So, as you know, most cells in our body have these like QR codes that are immediately identified by a recipient when they're transplanted and then they reject it. So there are ways to modify these codes and make them being accepted, which is very exciting. There's some even clinical, very early clinical data, but I think it's really a very interesting and I think very exciting time for cell therapies as well as disease modifying therapies.
Yeah, absolutely. When you can eliminate the immunosuppression, you have far more possibilities to give these treatments to patients. Yeah, you don't need to have these severe hypoglycemia. You can improve blood glucose control. You can maybe even in the future eliminate the need for insulin treatment.
Yes, I mean the data from islet transplantation shows the benefit, right? It shows the benefit of complications, rescuing the severe hypoglycemia, obviously improving HbA1c. And very importantly, we're doing some patient-reported outcomes in the islet transplant field, which shows what benefits or what risk benefits individuals living with type 1 are willing to take when it comes to getting a cell therapy, even if it includes immunosuppression or involves immunosuppression. So I think that removing the burden, the management that it requires, and all the burden of type 1, I think it's also something that needs to be considered in cell therapies as well. What are the risk benefits that individuals want to take, right? Understanding that from the clinicians. And I think, again, going back to your education, I think that requires education, right? Because there's the endocrinology experts and then the islet transplant experts. And then there's the rheumatologists that are maybe more familiar with immunotherapies. So I think we need to cross somehow in some way different clinical entities and maybe bring some centers, or I don't know at what level we're working very actively with medical affairs to bring these different practices and just focusing on the individual living with type 1 and getting professional advice or clinical advice that has some understanding on the different areas on immunotherapies or the islet transplantation or the endocrinologist. Not everyone maybe decides to go for a cell therapy or disease-modifying therapies. But I think
Hmm.
it's important to bring that united component, I think, in the
Yeah,
future.
that's really important. So you need to combine different therapeutic areas. You need to combine specialties. It's not just an endocrinologist, as you said. You need the different specialists to work together and understand the whole thing. Yeah, good, good. So we're looking to a bright future, it seems.
It,
Hopefully.
I,
Yeah.
yes, I believe so. I mean, there's been great advance and improvement in technology, and I think that's something that we need to recognize. But
Mhm.
still, there's challenges, and I think there'll be a choice. Again, it
Mhm.
may not be a cell therapy with immunotherapy. It may not be a choice or that everyone would like to do, but the
Mhm.
choice is there, and I think people would need to understand.
Mhm.
I'm surprised that sometimes the islet transplantation, the cases that are being done are self-refer, right? It's mostly people that read about and they obviously they fit the criteria, but they never heard. So, and
Mhm.
that's, it was never presented to them as an opportunity or as an alternative.
Yeah,
So I
because
think
people
that,
don't know,
yes.
right? It's
So I think that's exciting, and the same thing with the teplizumab. With now
Mhm.
we have a therapy that can delay the clinical diagnosis, and it's
Mhm.
still, there's still some challenges of adoption, but I think it's exciting to see the first disease-modifying therapy approved
Mhm. Absolutely.
now. Yeah. So I think there's going to be advancements that are going to be quite exciting and
Mhm.
provide new therapies
Right.
and choices.
Absolutely. It's always good to see a drug approved because then the interest is growing, growing, and there's much more coming after that. That's
Yes.
good.
And going back to the adult diagnosis,
Mm-hmm.
I think that there's an urgency as well, right? I think because
Mm-hmm.
there are so many, now I think there's been 6 or 7 disease modifying therapies that have shown some maintenance of C-peptide in the clinical
Mm-hmm.
trials that we've been running and some other organizations as well.
Mm-hmm.
Um, and these are mostly compounds and therapies that they've been used in other autoimmune diseases. So some of
Mm-hmm.
them may need a whole development plan, but some of them could be used and move forward in a bit efficient way. So I think the opportunities are there.
They are definitely, yes. And if you summarize, what do you think is the most important thing that the research community needs to really understand about adult type 1 diabetes and to ensure that these therapies can reach the patients?
I think that there may be some signs that when an individual with diabetes is diagnosed, again, I mentioned some of them, may not fit the profile of a type 2 based on body weight, hypertension, or on some other indicators. It's hard now without this machine learning. Maybe that's what
Mm-hmm.
we're trying to do. But if there's definitely suspicion or there's any test, there are C-peptide tests, there are
Mm-hmm.
autoantibody tests,
Right.
um, there's some genetic tests. So I think it's important to consider or at least bring. I don't know. What do you think? You're in the clinical field. How many every maybe there needs more understanding on type 1 and type 2, right? Maybe we need to
Mm-hmm.
start from
Yeah, we start.
from
Yeah, yeah,
early on, like,
yeah.
okay,
Rightly,
there is
right.
another type of diabetes, it's type
Yeah.
1. So
Mm-hmm.
I think that's where we need to start, maybe some,
Absolutely.
that
Agreed.
there is another type
Mhm.
1
Yeah.
diabetes, so autoimmune. It
Right.
manifests
Right.
this way, but
Hmm. Yeah, I
there is,
agree. Education is
yeah,
very important, and I think you at Breakthrough T1D actually do this a lot,
yes.
and you have
Mhm.
the community, and it is really really important, and not only by educating, but also by increasing the clinical research in this area. Because if you have the studies, this also gets known to the healthcare community, and the awareness is rising. I think this is also very important, and it was a major focus of our discussion. I think the diagnosis in the adult patients, as you said, is key to also get more patients into clinical trials, be able to
Mhm.
test more drugs, more therapies that might have more side effects that you wouldn't start in in children, for example, because you don't have the experience there. So I think that's all very important.
Yes. Again, the opportunities are there. And I think going back to the core of educating the clinical community, I think
Yeah.
that's can help advance. I mean, we're doing so much, but we need the community to get engaged and to get involved and spread the benefits and for the best of people that are presented with diabetes.
Thank you very much, Esther. This was really a great conversation, and I learned a lot. We had a lot of interesting things, and thanks a lot for your time.
Thank you so much. Thanks for having me and giving me the opportunity.